Thank you for the invitation to come here and give you my interpretation of the big recent fluid trials. This is my slide on potential conflicts of interest. I have received, not me personally, but predominantly my clinical department received honoraria money, and I received travel reimbursement from several companies manufacturing fluids. And I've been to the EMA. I reported to the Pharmacovigilance Risk Assessment Committee Advisory Board, and it was very impressive to be there and see that building, which looks like a very hostile environment where you have to identify yourself before you can get in and bring up your thoughts about what is out there according to the evidence. We recently read, and actually it was published on October 25th this year, that hydroxyethyl starches should no longer be used in patients with sepsis and burn injuries or in critically ill patients. There may be restricted patient populations where HACE should still be available. This was the statement we have out there so far from the European Medicines Agency. And there is that CMDH statement, which is an information for us healthcare professionals. There are predominantly 6 points, and I want to go through these points quickly. As mentioned earlier, sepsis, burn injuries, and critical illness are contraindications now. HACE solutions should only be used in the situation of hypovolemia, so for a treatment of hypovolemia due to blood loss. This is the new CMDH recommendation. Another point is that HACE solutions should be used at the lowest effective dose for the shortest period of time. And this requires a continuous hemodynamic monitoring. HACE solutions are contraindicated in patients with renal impairment, and kidney function should be monitored after HACE administration. And finally, HACE solutions are contraindicated in severe coagulopathy. So, to make that point clear, contraindications against the use of tetrastarch, according to these recent publications, is the list, as you can see here on that slide, going down to severe liver dysfunction. Of course, hyperhydration, including pulmonary edema and dehydration, are also contraindications. My personal interpretation, due to all that stakeholder reports and the procedures that have been done since early this year, I would say a good drug was kept in our treatment repertoire, but still resuscitation was successful, but the outcome is not perfect. We have to consider medical legal restrictions, medical legal aspects, and the relevance of the restrictions is important. The contraindications against the initial volume resuscitation, however, especially in the septic population, is irrational to my understanding. It's not a bad drug, but it was a bad use of a drug. Only bad news are good news, at least when you read the newspapers. But we should take care of all the good information we have out there. The restrictions in surgery and trauma are irrational and not evidence-based, and they are not practicable. Because to test renal function 90 days after patient's discharge or after HACE administration is not feasible. And severe coagulopathy, what does that mean? It is not further specified in the recommendations and statements. Is it some degree, some reductions in clot strength in the rotem or TAC? The use of alternatives will be our answer, but some of them and most of them are less investigated, risky, and some of them are more expensive. So what were the big fluid trials in critical illness? The VSEP trial, 6S, CHEST, and the CRYSTAL trial. Many of them multi-center with a good design, which means blinded parallel group, pragmatic approach, randomized clinical trials. So the highest evidence level we can achieve. Good news are good news. A big trial in critical illness is the CRYSTAL trial, which shows the efficacy of the initial colloidal volume therapy. As you can see here, the colloid-treated patients are summarized with the red bars. Mortality 20 days after the event was not a statistically significant different, but, and this was the primary endpoint parameter, but 90 days afterwards there was a statistically significant difference. Patients exposed to colloids had a higher survival rate. Also, some more soft outcome parameters such as ventilation-free days, vasopressor-free days were better and higher in the colloid-treated group, which means that the weaning period was easier and better. Renal replacement requirements were not different between the groups. So, the good news are summarized here in that chart, marked in green, 90-day mortality better in the colloid-exposed group, no differences in renal replacement requirements. Time to stabilization was faster when done early in the Christmas trial, also a good news. But in the 6S trial, tetrastarch was worse, and patients exposed to tetrastarch had a higher 90-day mortality. What was the cause of death? We don't know. And autopsy would have been a mandatory requirement in order to link and to find an association or a causation of death. If it was only a recurrence of cancer, this can hardly be a problem or cannot be associated to colloid exposure. In the chest trial, the requirement for renal replacement therapy was higher in those who were assigned to the colloid group. So this was a bad news. But unfortunately, the trigger for renal replacement therapy was not defined in that trial. So we do not know whether it was simply, let's say, hyperhydration that led to the initiation of renal replacement therapy. The length of renal replacement therapy, however, was comparable between crystalloid and colloid patients. We had heard earlier that, and Niels said that the proof is overwhelming according to the chest trial that we do harm our patients and that HACE is nephrotoxic. When we go back to the original data of the chest trial and you do some simple anesthesiological oriented maths, then you can see, according to the raw data given in the publication, that there were 235 patients that required CRRT. When you do that chi-squared test, then you end up with a p-value of 0.044. The authors reported 0.04. So this was statistically significant. The main output, the main message of chest trial: more renal replacement therapy cases. But let's do a mathematical calculation. If only one patient in the HACE group would not have required CRRT, and one patient in the crystalloid group would have required CRRT, so only 2 patients out of 3,000, then surprisingly, the p-value would not be significant anymore. It would be 0.054. The whole study, which is at the top level of quality of evidence we have at the moment, tells us that 2 patients out of 3,000 could make the message completely different. So it is always about our trust in the data, the trust in the interpretation of results. But if I may be honest, my confidence that this should change our way of thinking and our way of treating patients is very low. When you do the same for the 6S trial, it looks quite similar. According to the raw data in the publication, 78 patients with HACE needed renal replacement therapy. This ended up finally in 0.044 p. Only one patient in that about 800 patients, if he or she would have required CRRT in the crystalloid group, this would end up with a p-value of 0.054. before. One patient could have made that message completely different. So again, my confidence that this should make us reconsider our way of thinking and our way of treating patients is rather weak. The randomization after initial volume stabilization has already been mentioned over and over, also on this conference, with CVP values as mixed venous saturation and lactate levels being in a range that is not really indicating the need for colloids or the need for volume stabilization. This has been discussed over and over again. But for me, for my simplification, recommendation against the initial colloidal volume resuscitation cannot be derived from these three big fluid trials. There are other open questions, such as, what about the ethics committee approval for the use of a drug, and all colloids and all fluids are drugs, in their known contraindication? And I'm now, for example, referring to the VSEP trial. What about informed consent, or the waiver for an informed consent for the use in a known contraindication? In Austria, you would have to inform and get the informed consent, especially when you work in a known contraindication, and renal dysfunction, or CRRT, has been a contraindication ever since. Financial conflicts of interest are relevant and are marked with a bias point when you grade the evidence. But there is something else that may be in conflict with your interpretation of data, and that is called intellectual conflicts of interest. I think when you followed the discussions and dispute recently, also in the newspapers, then you will understand what I mean by intellectual conflicts of interest. What about the EMA? I think it would be mandatory to look into the raw data, and unfortunately, no data inspection before the suspension of HAZE or the definition of restrictions have been done. What about the journals, our meta-analyses and Cochrane reviews? Obviously, there are no concerns about ethics, methodological issues, and safety concerns I have shown you earlier. But for me, this is of relevance. I learned from these three big trials that prolonged colloidal volume therapy must be avoided. Without indication, we should not give any drug. We should look at preload and volume responsiveness, and we should be very much aware of contraindications. There is not one magic single bullet. Of course, we could do surgery with muscle relaxants only, but this would be unethical and not really good. Infusion therapy with colloids only, it's not good either. So we need all strategies in our intervention repertoire. No indication for colloids is the absence of intravascular hypovolemia. If we use it, then this could be called indiscriminate drug administration, according to our friends, the lawyers. Indications for colloids is hypovolemia with impaired tissue perfusion. The challenge, however, is how to monitor it. Of course, there are workshops here and sessions here to get more insight into perfusion monitoring, but still, at the bedside, this is tricky. To investigate intravascular filling status, to look into the microcirculation in various organs, and probably also the endothelial barrier function. The way to go further, in my eyes, is to target all our interventions, to go for individualized, personalized medicine, tailor the drug administration in its indication. The very recent guidelines on the management of severe perioperative bleeding, which came out at the European Journal of Anesthesiology this year, of course is dedicated mainly on how to stop bleeding. But this guideline, which is really broad, has also a chapter which is dedicated to increasing patients' tolerance to bleeding. You can find all the statements, recommendations, and suggestions of the guideline at the smartphone app esa.perioperativebleeding.org. And I would like to pick out some cherries of our guideline, which actually filled one issue of European Journal of Anesthesiology. Message number 1, avoid hypervolemia. With a 1B grade recommendation, we do recommend avoiding hypervolemia with crystalloids or colloids to a level exceeding to the interstitial space in steady state and beyond an optimal cardiac preload. Preload optimization also got a 1B. Aggressive and timely stabilization of cardiac preload throughout the surgical procedure, especially in the bleeding patients, is recommended. And what about tissue perfusion? Well, the monitoring tools there are limited, but at least lactate clearance is one we can go for. Of course, capillary refilling or the temperature and the color of the patient's skin are very helpful indicators, but serum lactate clearance is also something we recommended with a 1C. Monitoring only pressure parameters and probably heart rate is not enough. And all the data that were used and based on these pressure and heart rate parameters, which were finally used to assess the efficacy of colloids versus crystalloids, are, not helpful. So a crystalloid versus colloid ratio cannot be derived only from these pressure parameters. Yes, we do have meta-analyses, systematic reviews, but what goes in will come out, and they are not in the end helpful because they are just pooling the study limitations together. And the same, unfortunately, holds true with Cochrane analyses, which are not helpful, only looking into these data that were gathered with the limitations I mentioned earlier, also with the statistical limitations. There is no evidence that one colloid solution is more effective and safe than the other, and also albumin is dangerous. This is the conclusion of these misleading reviews. How can we get better? How can we proceed? Well, recently we sticked our heads together and thought, what could be an algorithm or helpful guide how we can do management, fluid management in critical situations and in septic patients. And here, hypovolemia is on top. This is the indication for our intervention and the trigger for our intervention. And there, metabolic parameters such as lactate, but also preload and fluid responsiveness is upfront. Then it is important to look at the time interval that passed after the onset of shock. When it is longer than 6 hours, you go to that stop sign. But when not, you go further and evaluate the patient whether he or she has pre-existing renal problems. If not, go further and think about the dosing and think about the maximum daily dose. So this is an algorithm which can be helpful probably. In fact, we do have studies that looked into that parameter of lactate clearance, for example. And here in this head-to-head comparison between tetrastarch versus saline, the authors found that in penetrating trauma, lactate clearance is better in those patients resuscitated with the colloid. And also from the elective surgical population, in another big trial, I would say, by Benes, implementing a kind of a algorithm, they found improved tissue perfusion, lactate clearance in those patients that had a goal-directed monitoring-based approach. Less complications. It's not in the elective surgical population, it's not about mortality, because luckily mortality rates are very, very low. So we cannot look at mortality differences only. We have to look also at the morbidity hints and alarm signals. And in this study, morbidity until day 30 was significantly lower in the targeted group called the Vigileo group compared to the control group. And when just considering that a number of complications will end up also in increased costs and resource use and so forth, then this really becomes an important piece of information, a big trial. Other big trials in elective surgery are this by Philip van der Linden, published this year in Anesthesia Analgesia. Pooling all the data from elective surgical patients together, he reported that the colloidal volume therapy is associated with patient safety. Why? Mortality lower, transfusion requirements equivalent, not higher, and renal replacement therapy demands not higher. Another meta-analysis further more or less supports this conclusion. This meta-analysis was done by Martin and published in Anesthesiology this year. The important diamond, the important key figure in this publication is exactly on the 0 line. So we are not harming our patients when using colloids. But still, we do have that statement from the EMA. HAES will be available in restricted patient populations. Since there was a lot of rumor and a statement, a letter, an open letter to the executive director of the European Medicines Agency, we thought it is important to publish and to send a counter statement. This was written by 6 authors and co-signed by 71 authors. So it is somehow a mirror and echoing what many of us believe. The alternatives, after having interpreted and seen these big trials and after having seen our medicines agency's response, need to be carefully balanced and evaluated. Of course, we do have alternatives, but all of them need to be considered very carefully. But what is more important from my perspective is to have a good perfusion monitoring, a good hemodynamic monitoring, not only based on pressure parameters and heart rate. Thank you very much for your attention.
So, thank you. Are there some questions? We just have 5 minutes, I think, so before I leave the chair to Niels. No? I have a question. I learned from your lecture, common people always say lies, damned lies, and statistics. Do you think that statistical hocus pocus is cheating us, or in our decisions we have to make in clinical practice?
We have to just be aware of what we understand and what we want from our statistical analyses. If you would have a rope when climbing and you knew that in a 5% chance this rope will break and you will fall down and probably die, would you trust that rope? We, in our understanding, think that a 5% chance is okay, and 0.05 doesn't mean anything else, but we accept a 5% a chance of being incorrect. It is not hocus pocus. A chi-square test is a very simple one. You can just do it with your
I know it.
with your fingers. But I did some hocus pocus, if you will, just by not me myself, but an anesthesiologist in Austria, Janet Kreuziger, who is very interested and very good in statistics. And actually, she did that exam or this math analysis with just changing 1 or 2 patients in the various groups. So I wanted to make you aware that our interpretation and our trust is dependent on our statistical analysis and our understanding on it. It's not hocus pocus, it's what we believe is important.
Yeah, I do believe, but maybe we need more information on the statistical approaches people are using.
Probably, but people who are very good in statistics tell us that when you have big cohorts, more than 3,000, 7,000 people, then it would be adequate not to go for a 0.05 level, but rather to an 0.01 or even lower, just in order to decrease that chance of error.
I fully agree, because the 0.05 was introduced by Fischer, and it's just arbitrary. And I know that in quantum mechanics, they need a p-value of 0.0000 to be significant.
Yeah.
So in medicine, it's 1 in 20.
Yeah.
It's maybe wrong. Thank you. Are there other questions from the audience?
It's on.
Would like to touch at this point because I think I can buy everything. But if you play this game, you come out saying the low tidal volume is absolutely false. Because if you change 3 patients in one group and you put in the other patient, you get out losing all significance. You just say one thing to me which was completely wrong. When you say going from 0.04 to 0.5054 would change completely our judgment. Maybe your judgment, not mine. Because to me have a 004 or 005 or 006 is exactly the same thing. You have just, because it's an arbitrary, it's just the probability that you are said to be wrong. If I have a patient, and I have 10 studies saying, as an example, that P is 0.1, and I have 2 treatments available, would you choose 0.1 for your brother or your son or the 90% if you go to the casino? So you have to be careful playing with the statistics. Because this, yes or not, is a misunderstanding of the statistic. Statistics is not a god. It's a tool that we use to have a more or less probability in a rational treatment. At this point, you have to justify why in a rational treatment, if you love colloids, you may use colloids maybe in patients 70 years old with a when you have alternative. This is the problem. If it would be only with this product, I would accept this compared to the risk. But if I have alternative, why should I use? Tell me only one good reason. Why should I use that I kill with the colloids or kill with albumin? Maybe I have this potential. This is foreign body, my dear. You are injected foreign body in the blood. After 10 years, you find it in the tissue. And this to me is more convincing than whatever trial in the world. But be careful saying 004 and 005 because it's impolite. It's very misleading, this one.
I'm sorry, I tend to disagree because our way of interpreting, reading the results is, was it statistically significant or not? And this was the only significant information in the test trial, and I'm absolutely sure that the number of patients included, 7,000, and the p-value below 0.05 was a main trigger for doing all that, what happened later in that PRAC assessment. I'm absolutely sure about that.